Yeah, so let's just start off where what we talked about just now with struggling with success. Can you say something about that, Ange, as we get started in this interview?
Yeah, so I was just sort of saying one of the things that I'm kind of struggling with at the moment, and probably have my entire life at different levels, is some of the feelings that start to get mobilized in me, and then the anxiety that comes up related to starting to be more successful in my career or in my personal life. And so I was just sort of mentioning to you, Thomas, that, things in my world are going well, so I'm working at the Centre for Emotions and Health now. It's like my dream job, and I'm working with Dr. Abbas, which is my dream supervisor. And it's a really exciting time to be in this position, because we have a provincial plan that's going to go forward, and to see if this might get funding. And there's some media going on around MUS, the medically unexplained symptoms. So there's lots of things happening that are really, really good. But of course, when anything's really, really good, there's like a part of me that wants to pull away and go into myself and kind of cut off from it all. So I can just notice some anxiety, and maybe at times some low mood that happens around success, which is so interesting, because most people think, well, you should be pretty happy that all this is happening. And I am, partly, but I'm also having some other feelings about doing well and doing the things that I always dreamed of doing. And that's, I haven't fully formulated exactly what that's all about, but I know that there's guilt in there. So, and you seem to be sort of nodding in like you understand that. And I'm wondering if it's, it's a universal thing, I think. I hope I'm not on my own with this.
Yeah, I think so. Yeah.
Yeah.
Yeah, and I mean, that's not where I am right now in my own process. It's not about anxiety about it. It's more I don't know what to make of it, really. Not yet, but things are going very well here on my side too.
Yeah.
We just we got approved to do pre-core training within the clinic where I work. So that's starting off in a few months.
That's amazing.
Yeah, so that's also, I really feel that my team and I, that we're in this expansive place where we're growing as a team, and we're growing as persons, and we're hiring more staff and so on. So it's
so there's lots of good things, and I think there's lots of good things happening in the, not just the ISTDP world, but just in terms of the psychotherapy world, and expanding, and more people are interested and open to these ideas. So it's a really wonderful time for opportunity. But regardless of that, it triggers all our own stuff up. And I think there's most definitely for me been periods of times where I've had to process loss. It's almost like every time I take a step towards success, I have to deal with a chunk of grief and guilt before I can kind of allow myself to take that next step. So it's almost like I take a step, I have to do this processing before I can take another step. And I can't prepare for it. It's just going to be whatever shows up every day, and trying to not sabotage success and do the emotional processing. Isn't that what we want to help our patients with and our clients with, is to take these successful next steps, whatever they are, without sabotaging themselves somehow. And so we're all in that process too, and I'm certainly in it. So it feels good to share that and say that this is very normal and human. Yeah.
Wow, it is. It is hard, isn't it?
Yeah, big sigh, Thomas.
No, I just think that it's so counterintuitive in a sense. This thing where you grow, and the growth in itself is a loss process where you leave something else behind, and
there's a lot of pain there, and learning. I'm training currently with John Fredrickson as well, and doing some training of trainers stuff, which is just wonderful. And he speaks a lot about the learning process. You know, in order to learn and grow, it's really painful because we have to open up to what we don't know, all the things that we didn't see that now we're seeing, all the opportunities that we missed that now are available. So it's this really conflicted place of now we see it, but we didn't. So it's kind of letting go and grieving and opening up space to take in these new opportunities without doing something that prevents us making use of that learning opportunity. So without getting critical, without sabotaging, without avoiding, without detaching, in order to make use of what's there. But it's painful for sure. Yeah.
It is. I know that I mean, or I would assume that you haven't always been this open to pain, growing and so on. So what about, we talk a bit about how you ended up where you are right now in Canada and working as a psychologist with medically unexplained symptoms and ending up where you are right now.
Yeah.
I don't know.
How did I end up here? It's a good question. Well, as ever, my unconscious drove me, but I didn't realize it at the time. I would say that for sure. I mean, what can I say? I trained as a psychologist. I finished my training in the UK in sort of 2011. But randomly, we could say randomly, or we could say serendipitously, I ended up on an ISTDB placement with Dr. Joel Town, who now works with Alan, and we're all here together working at the Centre for Emotions and Health. So it was an utterly random placement. And when I went on that placement, I had experience of the usual models, therapy models, CBT and EMDR, and I was quite getting into EMDR. But I was still having a real heart-head lag. Like I just didn't feel like I was connecting with my patients, and I was thinking cognitively or consciously, and it just, for want of a better sentence, it didn't do it for me at all. And then I started this ISTDP placement with Joel, and I was like, oh wow, this is something that's really sitting with me inside my heart. But it is so hard and challenging and complex to learn. But there's something in me that is just driven to do things that feel right, but are really complicated and hard. So that was the start of my journey, and it was almost like I opened up this ISTDP, something inside of me, and then I couldn't get enough of it. In fact, I would say I became obsessed with learning the model. And I think the reason for that is because for me, it's not a model. It's not something you're just doing to someone. It's an intense way of relating and connecting and having a really deep human experience that I almost think I was missing in my own life, with my own people closest to me. It's almost like I couldn't do this connecting thing that ISTDP allowed me to do with my patients, which is this really bizarre and also a very painful conflict, because I now have a method and a model of connecting deeply as I've always wanted, but I still struggle to do that with my family outside of the setting, right? So there's always something about that, but it was just so attractive to me in that way. And then in terms of the MUS specialty, you know, again, I wasn't conscious of this, but the job came up when I was in the UK. I heard about the job through Patricia Coughlin, actually. She told me about the job being available, and also it was mentioned maybe on the listserv. And I just felt this really strong desire to work with doctors, like just to be at the front of primary care and to be interfacing with patients at the beginning of their journey. And I knew the only way to do that would be to work with doctors and nurses at the front line, if you will, because often psychology, we're in a secondary service and we see people years and years after they've come through, but I've always been attracted to this first line work. And so this job enabled me to do that. And it just happened that I had the qualifications I needed to go for the job. And so I interviewed with Alan, and I interviewed with the heads of primary care here in Halifax in Canada, and got the job. And so began my journey of beginning to specialize in ISTDP, in medically unexplained symptoms, but then also working in primary care. So it kind of coalesced all these kind of things that were sort of at a subconscious level mainly that I was really interested in, and brought it all into sort of one zone. And so then I started my process of learning lots of things again from 2015, which is when I moved here. So yeah, that's how I've ended up here doing what I'm doing.
So this is the first job that you have in primary care, really? You
Yeah.
didn't?
Yeah. I didn't. I mean, I've been working with doctors a little bit in my previous job as a psychologist, but it was really more just contact through letters and maybe a bit about assessment pieces, but it was not like integrated with them. And that's what really, as well as working directly with patients, what really stimulates me and gets me excited is working with other professionals who maybe haven't had the opportunity to have so much training and understanding in how emotional factors would cause or contribute to medically unexplained symptoms. And so that's really exciting to me, to be able to teach people small bits of information that can make a massive difference to patients at the front line. So if anything, that's the thing that I'm most passionate about, I'd say, for sure.
And how come that is one of your great passions?
Another good question. Well, I think I know it's connected to family stuff. So my mum was a nurse, and a lot of my family are in the healthcare profession. So there was that kind of always being connected to healthcare somehow. But also, really, I think I've always been driven by a desire to basically try and never have a patient go through what my mum went through at some unconscious level. And I know I can't change the world, even though I want to. But so as a bit of background that I mentioned, started talking about in the last few years, is about my mum's. She had a physical illness called lupus, which is where you sort of parts of your body attack other parts of your body. For another want of a better phrase, where it can attack your organs and kind of hurt you all over your body in different ways. And so she had lupus before I was born, and it used to flare up and go down, right? And so one of the things that can be a big trigger for lupus is this stressful experiences and stressful situations. However, my mum, she only got treated for the physical part of the problem, and never really had anyone to help her with her anxieties, with her worries, with her even paranoia that would happen sometimes when she'd be having a lupus flare. And so only half of her problems were treated. And because the doctors didn't know how to help that other side. And so my experience was that her treatment would be okay if her anxiety and worries around the treatment were helped. And so because that other side wasn't treated, the emotional side, it massively impacted her ability to take care of herself and use the treatment on the physical side. And ultimately, it led to her death in some ways, in the sense that she became so paranoid and worried about the drugs that she was taking that she stopped taking the drugs that would keep the lupus flares down. And so, that very, very painful experience of a way that I could never understand at age 10, like from 7 to 10, 11, just has sat with me my entire life. And, wondering why nobody was asking her how are you doing? How are you doing inside emotionally? How are you feeling? What are these worries? Why are you worried? Can we help you with these worries? Validating her experiences and helping her manage her anxiety so that it didn't get to the point where she'd become paranoid. Because she'd be very lucid. She'd be very lucid in times when the lupus was not in flare. She'd be just sort of healthy without worries. But with that, there was all this increase in anxiety and worry, which got in the way of treatment. And so whilst we wouldn't say lupus is a medically unexplained symptom, the emotional factors that were with that really complicated and impacted her ability to take care of herself. And so if doctors are able to assess anxiety, they know how to talk about it, they're able to offer some form of treatments, then maybe we can help people take care of themselves better so that they stay consistent with their treatment, which is going to then help them physically too. So that's one of the biggest drivers why I'm here, is I don't want any other patient to have to go through that. And I think, you know, since the 70s, 80s, things have massively changed, and actually doctors are much more aware of mental health and emotional factors, but we've got so much work to do, so much more work to do. And I find that ISTDP has a very good framework to offer really clear ways of understanding anxiety. And so that's why I'm very passionate about this model too, because I think it can be taught, and I think we can observe what's happening in patients and help doctors be able to do things at a low level. It doesn't need to be complicated, and they don't need to be therapists to understand anxiety or emotional factors.
Just continuing on where you just stopped, like, do you have that experience now from working in primary care then for a few years, that you have colleagues, doctors that catch on to the model? And
very much so. Very much. I love working with this group, and I love it because they are so thirsty for this kind of knowledge, and it just is that often they either haven't been offered the right kind of training, or they just don't have the time. And so you know, it's a privilege to be able to be given the time to educate people at the front, the primary care, so doctors and nurses and other professionals. And I find that once they begin to understand why this is important, why everybody needs to be able to assess emotional factors, that they're just very, very hungry for it, and they want this kind of training in skill building, let's say. So not just theory, but actually, how do we apply this with the patient that I'm going to see next in 15 minutes? That's what doctors want to know. And that's a fair enough question, because they only have this time often to work with people. And so we have to find ways of simplifying some of these basic therapy skills or assessment skills so that doctors can begin to do this on the front line, and more and more and more doctors can do it as it grows. So that's kind of one of my aims, is to grow this so that it's available to all doctors and who are interested in it. So yeah.
Yeah, and that's my mind just starts thinking about, I mean, this is so, because this ISTDP model, it's so complex.
Yeah.
And and in my experience working with I mean, severe cases of medically unexplained symptoms, it's so complex with all the fragility that you have in this population.
Yeah.
So trying to explain that to doctors, that's not an easy task.
No,
and trying to present like the watered down basic model, that is actually something that you can teach someone in 10 minutes, as compared to the total immersion in ISTDP training weekly for like, how many years have you been training in ISTDP now?
Well, since 2008, I've at least been exposed to it since then. So we're talking
so 10 years.
And
you're still struggling
for sure.
to grow and to help more patients.
No, it's a very good point. And what we're talking about is quite different. So us working to treat these conditions is very different than doctors having a basic understanding that situations happen, emotions get triggered, people get anxious, and then they might engage in defenses or behaviors that shut down the emotions. So we're really talking basic concepts, triangle of conflict concepts, and especially what is super interesting to doctors is the anxiety pathways. And that actually in 10 minutes, you can most definitely ask somebody about the stress that's going on in their life And you can most definitely begin to observe what happens in their body when you ask that question. Do they get tight and tense and take a big sigh, which suggests it's striated tension, so the somatic nervous system? Do they kind of slump and get a bit depressed or a bit sicky or nauseous in the belly? And that'd be more of the sympathetic nervous system. Or do they kind of seem to go away and dissociate or get dizzy or funky in their minds, which might suggest it's the parasympathetic nervous system? And then you ask them the question, what symptom would come depending on what anxiety pathway that person's in? They can answer it every time. So they don't need huge complexity to begin to understand what the body's doing. What they've not been taught is this way of what we would call emotionally palpating the system. So in the same way that they would do a medical palpation of the abdomen, what we're saying is you can do this emotionally. And you can ask some questions that might trigger some emotional response, and you can observe the body. And then your job is just to feed that finding back to your patient and see if they agree or not. And that simple process of connecting emotions with anxiety, with physical symptoms in the body, can bring a huge change to that patient. So that's not in-depth therapy work, that's simple linking. But it can make a huge difference for the patient who is worrying that they have some horrendous disease, or that they need to wait on a wait list for a GI investigation. And then for those 2 years that they're waiting, their anxiety systems are getting worse and worse. So they think they have a much worse disease at the end of it. And you can cut through all of that if you're a doctor and you're able to feed back what you see in the room, as well as ruling out for major medical disease, right? That's really important that doctors continue to do their job. That's what they're there to do. Think of it this way: they're going to continue to do the job they've always been taught to do, but they're going to add on some of this emotional understanding, right? And so when we think of it in that way, you're adding a piece to what you already know. You don't need to relearn anything new. And you sort of make the links clear, then doctors get it, like they get it and they understand this. So it doesn't need to be complicated to understand why physical symptoms might be caused by the nervous system. It's just helping them ask the right questions and to begin to observe what's happening in the body. And that's going to take training for sure. But really, these are just about having, more informed conversations, if you will, that both tackle physical problems and emotional problems at the same time. So
I just noticed that I have some feelings rising as you say these things.
Okay, tell me what feelings.
I recall because I have one of the reasons why I ended up with a great interest in medically unexplained symptoms is my own symptoms. When I moved to Stockholm, that was, I don't know, maybe 10 years ago, I started having abdominal symptoms, specific ones. And I wasn't very worried about it, but it kept on going, and I had a lot of pain. And then I went to the medical system, and I had tons of examinations being done to me. And luckily, they didn't find any structural changes or structural damage or any tumors or cancer or nothing. Nothing was found. Even though I had these really strong symptoms that were in periods really incapacitating. I couldn't go to school and university for a while. Really strong stuff. Actually, it wasn't until a few years later that I started to study to become a psychologist, and I started going to have my own therapy. And my psychodynamic therapist, during the first session, she said, she wasn't working with the ISTDP model, and she wasn't, at least to me, she wasn't teaching me the anxiety pathways and so on. But she right away just said, "Oh, you have IBS symptoms. Well, that's probably a psychodynamic factor. That's probably an emotional thing." That was, and that in itself, just a moment, during the first session, that changed my life. Just to have someone tell me, this is emotional. This isn't about what you eat. This isn't about parasites that you got in Mexico.
And so if in the dream world that we're creating here, if you could have been investigated appropriately, but if you could have been asked about, you know, anxiety in your body and the stresses that are going on in your life, and observe what happens in your stomach at the time of that, a lot of this unnecessary suffering, let's say, could have been reduced. You know, and it's not so complicated. And my guess is what you're saying is that made sense to you, and you were like, thank goodness someone can see me beyond all these symptoms, can see something underneath, right? And so it only took someone to sort of say, I wonder if there's something emotional going on you might be getting stressed about in your stomach, that kind of brought some relief. It was like, thank goodness someone is asking me this question. And, you know, the literature and the research and my experience suggests that in general, not in every case, but most patients are looking for this kind of explanation. And they're just waiting for their doctor to bring it up. Right? Now, not everyone is going to accept this, you know, for sure. We have people who would think that's, you know, would be kind of adverse to that idea. But a lot of patients are actually, in the context of a caring relationship with a doctor, someone who cares for them, they're not adverse to being asked questions in addition to medical questions. And that in itself can bring relief. And that's really what we're trying to help doctors be able to do, is to just have these conversations and to stop this idea that it's something horrendous like parasites or something, a cancer going on in your stomach, right? If we can put that to bed early on, then there doesn't need to be as much suffering, and the anxiety system can calm down. And that in itself would bring a reduction in GI problems, right?
Yeah. It's really this work is just so important. It's an important thing to research and to disseminate.
Yeah, I think so. And I feel like that's the feedback that I'm getting from the people that I'm working with is, no one taught us about this, and now we see this. We can see this in so many of our patients. I'm so glad I'm learning this, as well as I'm such a bad person for not knowing this already. So that's a big thing that often comes up is, as we were talking about in the learning process, needing to beat yourself up because you didn't know what you didn't know. Right? And all the people that you could maybe have done things differently if only you'd have known this information. And that's a common barrier that comes up to learning. And so we just have to help some people take a compassionate approach, and you didn't know what you didn't know, but now you do, and you can go forward and help more and more people with this knowledge. So it affects us all. We're all in this. We're all human. We all have emotions. We all have anxiety, and we all have behaviors. And probably most of us have symptoms of different sorts at times, right? And so we're really talking about a human thing, not something that's out in the far reaches of alien land. It's really in us all. And that's what makes it difficult to talk about sometimes, is because it's in us all. And so we have to also recognize our common humanity between each other, rather than this sort of dichotomy between patient and doctor or patient and nurse. Actually, we're all human, and we all have this going on. And the sooner we can realize that and be okay with it, maybe the better we can help people.
Like changing the way we see the relationship between the therapist and patient.
Yeah.
These ideas of equality and common humanity and compassion for the patient, but also for the therapist and the doctor.
I mean, it's good to hear you say that. I am a bit locked into ISTDP world, so I haven't had much exposure at the moment to other therapies, at least in the last few years, but it's really great to hear that. And ultimately, if we could just get less caught up in what model it is that we're using or how we think about cases, and more get down to just connecting with people at a deep level in the present moment, we would be all doing better work and more effective work, regardless of the actual model we were using. And so it's wonderful to hear that there's these movements towards, we could call it a common humanity approach, right? And in the context of a deep connection, all this stuff is going to start coming up. And then how you choose to work with that will be dependent on your preference and the patient's preference and going forward. And good things can happen from that place. Just thinking, one of the questions that you sent through was about this. I really love this question that you asked about creating a law, Cooper's law.
Yeah.
So for the listeners, one of the questions you said was that there's a Cooper's law, and it's a law in physics. And I didn't have a clue about this law, so I looked it up. And essentially it's to do with electrons binding and creating lower energy. And it's part of a quantum effect, right? So, and I really love quantum physics. I'm very into quantum physics at the moment. And so I was thinking, and I didn't really know, how can I create a psychotherapy law? So I was thinking a lot about this. And it comes back to what we're just talking about. If you think of this idea of common humanity and, let's say, oneness. So at a quantum level, everything's connected at an energy level. And so if I could create a law, and I think it already exists, but if I was going to name it, it would be that whoever you are in the health service, any service, but if we're talking just health service, whatever model you use, whatever profession you are, the law that I wish we could all engage in or be aware of is, when we're sat with the person, is being able to see the person underneath the pathology or the suffering or the pain. So instead of just seeing the symptoms, that we actually see the person. So we're separating the person from their pathology. So yes, they might have all this suffering, and yes, they might have all this pain, but that's not who they are underneath. And so separating, person from pathology, or, their capacity from their conflicts, or, being able to see the energy underneath. If we could do that as a healthcare system, I think it would cut through some of the major issues we have across the world in our healthcare systems, which is this, oftentimes indirectly, a paternalistic, disempowering, kind of breeding dependency kind of service, where if we were able to see someone's capacity through all their suffering, we could truly help the person underneath. And I think that would change, it would change how we deliver healthcare service across the world. So that would be my law. It's only small.
But but the consequences are vast.
Yeah. But it starts, if not necessarily the quantum level, but at the individual level of the interaction between the professional and the patient, or the two people that are in that room. If it could start at that level, it would expand out. And so it's not like a law that needs any major shifts. It's about how you see people sat in front of you, and what is it that you choose to focus on. Are you going to choose to focus on just the symptoms? And I mean, it's important we validate people's symptoms and pain. That's not what I'm saying. So validation is important, but that's not who they are. That's not the only thing they are, right? And so that's how I try to approach every single person that I meet, is that you are more than what you're bringing in terms of symptoms and pain and suffering. You're much more than that. And so that's how I just keep connecting. And that's, Alan's idea of reaching through the resistance is just continual connection to the person underneath, and as a way of getting around all this other stuff that might be going on, it's kind of a direct focus into the person. And if you can stay there, and you can always see a good person underneath, a person who cares, a person who has value, and who brings, who has the potential to bring deep connection in other areas of their life, then I think we would be more effective in many ways. So that would be my law.
Hmm. And how would that sound then if you talk to a person using Cooper's law in your mind?
Mm,
How
mm.
would that sound when you talk to the patient? If you just give an illustration of that?
Yeah, I suppose it would be if someone was presenting all their symptoms and their pain history, it would be, okay, so I hear that you've been suffering. Um, but right now with me in the moment, what's going on inside of you besides your pain? What else is in there? What do you notice in terms of your emotions or your thoughts or your anxiety? What else is in there as we sit here together? So it's sort of offering an idea that there's something other than the pain or other than the symptom there. And it's an idea that, okay, but who are you? Who are you here as you sit here with me right now? Let's find out. And then hopefully you'd see a sigh. Or you'd see other things. But a sign that someone hears that you see them. And that's for me is how it would kind of look.
Hmm.
Yeah.
Hmm. Hmm. Yeah, I'll try and test it out next week.
Let me know.
Yeah, I think it's, I mean, when you talk about it, I come to think of like different situations during the work week where we had like colleagues talking about patients. I wouldn't say necessarily in a paternalistic way, but I mean, patient work causes a lot of rise of feelings in us too. And we're going to use a lot of defenses to deal with that. And
Right.
some of them are more malignant than others.
Absolutely. Yeah.
And it's really a challenge to, if we're going to live by this Cooper's law, then yeah, that's going to be a lot of hard work. And
yeah, and processing some painful feelings. It means
yeah.
we have to kind of look at, it's a good point for us to sort of think about is looking at our own stuff. As we're all human, we all have our own past and history and experiences. And it's really about being willing to look at that there's also stuff inside of us that might not be so healthy for us. So I don't think people maliciously or consciously don't see the person that they're sat with. I think it's an unconscious process about how we're just brought up, and how we're raised and the culture that we're raised in. And so we have unconscious ways of dealing, as you're mentioning, and some of them can be healthy and some of them not so healthy. And so we as therapists, we as healthcare professionals have a lot of work to do. In fact, just as much work to do with ourselves as the patient might have to do with themselves, put it that way. And I think if we can just put ourselves all in we all have to develop, and having an internal understanding of what's going on inside, if we are all in that bucket, then we can all have willingness to change and see what we don't want to see and go through painful process for the sake of growth and developments. So we're all in it together, whether we like it or not. Yeah.
Yeah.
Yeah. And but in a way it's kind of cool too. I love that idea that I'm no different from anybody. I'm no different to the patient that I'm sat with. I might not have the symptoms that they have, but I have the same emotions. I have worries, I have fears, I have defenses, I have pain, I have symptoms. I have all the same, the similar underlying processes going on. It just might not be the same output. And it means then I can deeply, whilst I might not have had the same experiences, I can deeply empathize and understand where they're coming from. And so from that position, then there doesn't need to be this judgment. And sort of a place, where two people are connecting without judgment is a really rare thing. And it can be a very beautiful thing, and it can bring very deep change if two people can sit there and try and avoid or push aside judgment and get to know each other.
Yeah.
Yeah. We all want that, right? Isn't that what, it's kind of like the baby mum interaction. We just all want this deep connection without judgment and without pain. right? Or without suffering. I mean, there'll always be pain, but without suffering. And so if we can find a way to do that within ourselves and with others, then it would bring good things.
Yeah.
Yeah.
Yeah. I would like that.
Yeah, me too. So let's do it, Thomas. Let's work on ourselves so that we can, you know, deeply connect with others, so that we can help others deeply connect with, you know, patients or the people in their lives, right? That could be how it expands out. And I think there's many people already doing that. But we can just make it a conscious kind of goal that we try to do this, you know, and let it expand, as in quantum theory, you know. We only need to do that with ourselves even, and a few other people for it to expand across the world in a way, you know. If we're all connected, us doing one thing with each other would expand across the world. If you think of it in that way.
Yeah. No, yeah, that sounds reasonable.
Yeah.
I mean, I think just I come to think of like the transformation that I've gone through for the past few years trying to learn ISTDP, and the changes that I've seen in my friends and my partner, just by, I mean, my way of relating being a bit different, and then
For sure.
that having these kind of quantum
effect.
effects. Yeah.
That's a really great point. If we change ourselves, you know, this is a really nice way to think about the work that we do, especially if we work in adult services and we don't necessarily see kids. I know that if I help a person deeply connect to themselves, that will by definition change how they are with their kids, with their partners, with their people at work. I don't even need to directly talk about that stuff, because you're changing the energy within themselves. So then they're going to go out into their world, and it will just make a difference without us even talking about it. That's the crazy thing. And so that's the cool thing that we can have as knowledge, is me helping this person right now not only helps me, but helps them and passes it on to future generations. And we don't need to ever talk about it once. It's just going to happen. And that's cool.
Yeah.
So it's wonderful to hear that, you know, your example of you doing work with yourself, how that impacted your relationships with your nearest and dearest, right? And that will then allow them to make changes with their nearest and dearest, and so on and so forth.
Yeah. It's I mean, it's so powerful to be somehow a part of all of this.
Yeah.
It's a great thing.
Yeah.
This ISTDP community thing.
Yeah. This being human thing. And the ISTDP gives us maybe some principles for how we make deep connections. So how would you explain ISTDP in a few sentences? And it would be that it's a model of relating, or a way of connecting, and it gives us principles to overcome the barriers to that connection. And it's at a simple level, I would see it in that way. And I would see many other psychotherapies doing the same thing, right? But for me, ISTDP sits with me, and it means I fully buy into it in my own self, not as just a thing, but something that's deeply integrated into me. So then I can be with people in a very integrated way, because there's no conflict with me in this way of relating. Like, I believe in it and I feel it. So it's not like I'm trying to get people to buy into something I don't really buy anyway. It's just this process of connecting. So that's how I would simplify ISTDP.
Yeah, and that sounds so easy, right? And the principles are so
so easy. Yeah, it's
like,
totally the easiest thing we've ever done.
basic principles, and then doing it in practice can be so hard.
Yeah, for sure, for sure.
So so again, maybe we should try and wrap this up for today.
Sure.
Uh, do you have some last words to say, or some?
Oh, well, last words. Well, we're doing this for the workshops in January in Sweden. So I just want to say I'm looking forward to meeting the people that are going to come to these workshops in Stockholm and in the south as well. And I look forward to, like, I have a real close place in my heart for the Scandinavian countries. So I always enjoy coming there and learning from you all too. Yeah, and just to wish you well in your work. And
No, I disappeared. Now you're there again.
Hello. So
Hi.
yeah, just wanting to to welcome everyone in January. Looking forward to meeting whoever might turn up. Hope we can learn from each other and do this connected thing together. And yeah, if the more of us that are on board with this in terms of human nature, common humanity, oneness, the more change we can create, and the less difference there is. This is not about being different. This is actually about how similar we all are, and that's what makes it difficult. So they'd be some of the final thoughts I would have. Yeah, and I just together we can make big change, but only together.
Yeah, I'm so happy that you're coming here, and thank you so much for having this talk now.
You're welcome. Yeah.
Um,
thank you for arranging it. It's a good way to connect with you, Thomas, and also hopefully from our connection we can connect to other people too.
Yeah, I hope so too.
Yeah.